So I am actually the speaker on this session, and I will be talking about Richter syndrome and what are the options. Looking for, here we go. All right, so what we'll go over basically is who gets Richters, for one, who are these patients, can we identify them? We'll briefly touch base on the biology of transformation and the abnormalities that we are seeing, and can we predict potentially these patients and when they may even potentially transform. We'll talk about some of the therapeutic regimens that have been tried and currently ongoing, and Richter-specific trials, and then additional models for studying the process of transformation, as well as models that we can start to address some therapeutic strategies. So when you look at the annual incidence of Richters for the overall CLL population, it's relatively a small percentage of patients. Only about 5 to 10% or so are transforming in their lifetime, with the caveat that 5 to 10% are heavily enriched and very high-risk CLL patients. It's also important from this study that was done at Mayo Clinic, where they followed about 1,500 or so patients kind of prospectively that had all received their care there. 40% of these patients transformed prior to any therapy during a period of observation. So that remains a problem, and that is something that we've seen in our own series that we'll show you at the end of this, where there's about 40% of patients. When you look at the Hodgkin variants, it's also a relatively rare occurrence. 90% of these transformations are large cell lymphomas, B-cell lymphomas, but about 10% of this rare transformation event are these Hodgkin variant lymphomas, which do worse than de novo Hodgkins, but definitely much better than Richter's transformation that goes to a DLBCL. So what does it look like clinically? When you see these patients, it's not subtle typically. They're having B symptoms, night sweats, debilitation, fatigue, rapidly enlarging lymph nodes. Literally within a week or two, they're talking about something that's popping up, and you have to obviously get them in quickly to see them. These patients have elevated LDHs, classically 2 times the upper limit of normal in a lot of studies. So if you're seeing LDHs in the 400 or 500 range or higher, you've got to be maybe concerned a little bit until maybe you go looking. Normal CLL is in that either normal or in that 200 to 300 range if it's elevated at all. Hypercalcemia, there's many case reports out there. We've seen it in our clinic. This is a kind of precursor and definitely is another sign that you start to see a hypercalcemia appear, that maybe you should be thinking differently about that patient and potentially looking for evidence of progression and or Richter's transformation. And then obviously when you're concerned, a PET CT is extraordinarily valuable. Numerous studies have shown the value of SUVs when you scan these patients, and basically this most recent paper had some of the best evidence that an SUV of greater than 10 had greater than a 90% probability of it being diagnosed as a Richter's. There was a few patients that weren't Richter's that had SUVs in this 11 to 12 range that kind of obviously crossed that threshold. But when you see it and you scan these patients, the vast majority are in this 15, 20, and even in a series that will show as high as 40. And so histologically, what does it look like? So when we talk about DLBCL, these transformations are, Richter's transformation is a CLL transformation. It's a unique biology and it is a distinct entity in and of itself, unlike other transformations such as follicular and along those things. So it's a very specific term when you're using it. 90%, like I said, are to DLBCL. Most commonly are in males, and these DLBCLs frequently lose the classic immunophenotype that you see with a baseline CLL. So you can't use it necessarily to say if it's clonally related or not, because a vast majority of them, 30% are remaining CD5 positive, only 15% are remaining CD23 positive. When you look at P53 staining, this is an acquisition event. This is something that's also seen in these patients. They are staining P53, and so they have disruption in this protein, and its normal function is no longer there. And so 80% of the Richter's component has P53, whereas if you're looking at the CLL phase, you will not be seeing it there. And important to note that these are ABC. These are non-germinal center lymphomas. These are post-germinal center. They're expressing MUM1, IRF4, and are commonly 85 to 90% in most case series are these ABC subtypes. And so again, when you look at clonality, which is very important in terms of the prognosis of these lymphomas, clonally related CLL is about 80 to 85% in most series. And when you're seeing a clonally non-related one, it kind of gets restricted to the mutated phenotype. So if you have an unmutated antibody gene, it's almost invariably going to be clonally related, where if you have a mutated IGHV, it's possibly on a kind of a coin flip if it will be clonally related or not, because those are definitely much rarer. And they respond differently. They respond like a de novo DLBCL to chemotherapy. And these true clonally related Richter's transformations are dismal. It's an end-stage complication of disease. It's very difficult to manage these patients and even enroll them in clinical trials. They're not eligible for a lot of them, and you don't typically have 2 weeks to wait to screen to get somebody to a drug. So their median overall survival is poor, and I'll show you our data as well. So the Hodgkin variant, 10% of these, there's kind of two distinct variants that have been reported in the literature. There's this type 1 where the Reed-Sternberg cell is kind of just in a sea of CLL, basically. And so is this type 1 Hodgkin variant. Then there's the type 2 that is the more classical inflammatory background, and this is the more commonly that we see, though there have been reports where the type 1 progresses into a type 2 that wasn't previously treated, it was kind of monitored, and then finally it progressed into this full-blown kind of classical Hodgkin's lymphoma. The clonal relationship patterns are a little bit different. It's actually, while this study didn't actually look at the actual IGHV, they used ZAP70 as a surrogate marker. It was the ZAP70 negative, which is a surrogate marker for mutated antibodies, were found to be the clonally related Hodgkin's. EBV status didn't seem to matter, and the histologic pattern didn't seem to matter either. And importantly, the histologic pattern doesn't seem to affect survival in a very small study of these very rare tumors and kind of retrospective in nature anyway. But median overall survival is about 44 months, and this is also very, as you've seen previously and what we'll show you later, is very classically of what we've seen. You can manage these Hodgkin's transformations. So what is unique in these patients that transform? So the case for these high-risk chromosomal abnormalities at diagnosis. And commonly, the stereotype B-cell receptor will become important. And then obviously Notch signaling. These patients have activated Notch signaling. And so when you look at patients and kind of chromosomal abnormalities outside of the routine FISH that we do, not that we do this clinically, you do find some specific abnormalities that I'll highlight here. So this study looked at a series of related CLLs and Richters, and also what I hadn't seen done in other studies is that they looked at CLL at diagnosis that had transformed later in their time course versus CLL that had not transformed, and their time point was at about 7 years. And so presumably ones that will not. And what we find is that basically a few things jump out. 17p deletion is enriched in patients that transform. About 32% of Richters had a 17p deletion at diagnosis. And what's interesting here is this deletion at 15q15. It was also at a relatively high percentage. 18% of Richters had this deletion at diagnosis, and it's an interesting gene. It's this MGA gene, which is called MAX gene associated, which is a negative regulator of MYC. And so you'll start to see recurring themes. We've seen recurring themes already going through this, and MYC is an important pathway towards transformation. So it may be something important. And at diagnosis, it's not really there. It's not that common, but in about 5% of patients at diagnosis. So this is just showing that this MGA disruption, and in this series, this is a different series, showed it about 7% at Richter's, and also it enriches in fludarabine refractory patients. So it's knocking the gene out, it's mutating the gene. And then on the right there, you see the relative mutual exclusivity. So, you know, what we commonly see are mutations in pathways such as MYC pathways, and so either NOTCH mutation, which is an activator of MYC, MGA disruption, which can activate MYC, or MYC abnormalities in and of themselves are commonly seen in these transformations. So stereotype B-cell receptors, there's increasing evidence that demonstrating the biological relevance of the stereotyped B-cell receptor. A third of CLL patients have a stereotype B-cell receptor, and this just kind of shows you the more patients that you sequence, it's unlikely that we'll be able to claim that every single CLL receptor will be potentially identical to one previously. And what's important is when you look at it, almost 40% or so of these stereotype B-cell receptors really reside in about only 18 or so of maybe, you know, I think it grows a little bit every time, but somewhere 60 to 80 different types of subsets that you can define. And the vast majority of these, and the vast majority of them actually associate with aggressive disease and high-risk mutations. And so you look at certain subsets here that are common and aggressive. The ones that are aggressive are kind of on the left there, as well as 8, which is the V-4-39, associating with NOTCH. They associate with SF3B1. They associate with TP53. There's no clear link to why a stereotype B-cell receptor would necessarily select for a certain mutation, but it is an interesting observation there and explains potentially the aggressiveness of some of these stereotyped receptors and their potential to transform associated with these mutations. So, and here's the kind of proof here. This is from diagnosis, a patient who had a stereotype B-cell receptor has about anywhere from 20 to 25% chance of transformation, you know, at that 5-year mark. And so these are patients that potentially, if we're using this as a clinical test, could maybe identify someone and potentially manage them slightly differently. So NOTCH1 mutations, these are one of the most common mutations seen at CLL at diagnosis, anywhere from 6 to 12% of untreated CLL. Most mutations are in this exon 34, resulting in this frame shift that ultimately basically deletes this PES domain. The PES domain is required for degradation of NOTCH, and when you lose it, you cannot phosphorylate it, and you do not get sent to the proteasome, and the transcription complex that NOTCH forms remains signaling in the nucleus, in the cytoplasm and nucleus. Recently, about 2 years ago or so, there are now untranslated region mutations that ultimately have the same effect. Basically, it adds a splice site donor, and this new splice product from the messenger RNA basically cuts out the PES domain, and you're making a NOTCH protein without it. So therefore, upon activation, it remains signaling. And what they've found is that they've gone back and looked at these in studies and shown that they are equally as bad as basically having a most common exon 34 mutation. Importantly, NOTCH mutations are not commonly acquired at Richter's. They're almost always there at diagnosis. They're almost always there at a clonal or subclonal level, and it is that potential subclone that then grows out and transforms. So this is not something that acquires. Again, something that we can use to identify a patient, potentially manage them differently at diagnosis, and shows some importance to identifying this mutation when we first see a patient with CLL. And why is this important? Well, when you look at how these patients do, they transform more so than patients who are wild type. And so basically you can see at 5 years, again, close to 20% of patients with a NOTCH mutation have a risk of transformation from diagnosis. These are patients that may or may not have even had therapy, and we see that frequently in the clinic. So the Richter's genomes are characterized by increasing genomic complexity, though it is less than kind of what we see in a de novo DLBCL. It's kind of in between. It's not surprising, I guess. When you diagnose a Richter's, there's about 20 new genetic lesions. CLL is not that highly mutated, and so we see about 20 new genetic lesions. These are chromosome loss, gains, mutations. And then when you see very end-stage Richter's where you have leukemic phases and patients are very, very sick and difficult to manage and control, at that point in time there's even more abnormalities accumulating. So it involves both copy number losses, mutational changes, but the unfortunate case is that the majority is loss of chromosome material. And a lot of it is loss in tumor suppressors and negative regulators. And so things get turned on, and what gets turned on are typically historically non-druggable kind of targets like MYC, NF-kappa B, and all these other proteins that lead to aggressiveness. Also, when you see mutational changes, what's being mutated are genes that actually regulate Notch signaling and other pathways that we know are important. So we frequently see that. MED12 mutations can be there, and so on and so forth. So what do we see at acquisition? So what are the things that kind of are being acquired, and what are the switches, so to speak, that kind of get turned on? So what's important to see is that this loci 9p21 that holds CDKN2A, that is frequently acquired in about 30% of patients with Richters and is rarely, if ever, seen at diagnosis of CLL, as you can see on the right side. 17p deletions, these are highly enriched in patients who transform, whereas they're at a small percentage in patients at diagnosis, as well as MYC gains. So we start to see AQ24 gains. Whereas we do see these at diagnosis in CLL, they are rare. You do see MYC amplifications. You sometimes even see classic translocations in CLL. But they significantly enrich in Richter's transformation. And then ultimately, we also see gains on 12. And trisomy 12, outside of its inherent association with NOTCH1, also has a high risk of transformation at baseline. And so we see these MYC gains. And I don't think we know necessarily what genes are at play necessarily there. So the CDKN2AB, this is common, and as I said, specifically acquired at time of Richter's. Hopefully we get 100% on that question at the end of this. And so basically it encodes two proteins, P16 Inc and ARF, and so the P16 Inc goes and is a negative regulator of the cell cycle, so you lose that, you turn on cyclins, and the ARF protein, the second splice protein, is a negative regulator, P53 through MDM2. And like I said, coexists with these other ones. It's typically mutually exclusive with trisomy 12. And so when you sum it all together, really it gets pretty easy when you look at what is going wrong in patients who transform. And really, they have P53 mutations, they have Notch pathway disruption and or mutations, CDKN2A loss, and or P53 mutations, and these MYC abnormalities. And they're affecting everything that you don't want to have revved up, cell cycle, DNA repair, proliferation, and so on and so forth. So we know that survival is poor after you transform. This is the OSU data that we've seen, basically showing median survivals of right around 6 months in that group on the transformation arm. And so historically, when we look at what have we done, we haven't really made a lot of progress. This is a table we kind of keep trying to update over the years. And fortunately, over the past couple of years, we've had a few trials that have reported that are Richter specific, only enrolling Richter's patients, such as the OCHOP study. That was really the only Richter specific study, but others had enrolled these patients. And basically what we see, and the results that you see, the overall response rates, CR rates, those are in the Richter's cohorts of patients only. But ultimately, you're seeing low response rates, 40% or less, minimal CR rates, and overall survival, even if you can get into a CR, doesn't necessarily mean that you're going to live a long time, such as we see in a DLBCL. And you need a transplant, basically, an allogeneic transplant to have long-term survival. Interestingly, selinexor, it's a very effective drug. They had a Richter study, being a specifically Richter study as a single agent. It can get responses. I don't think there were many CRs in the study, but it closed early due to poor accrual. So we'll see what those results were when they kind of work it out. They enrolled 30 of the 50 patients that they wanted. Pembrolizumab, obviously PD-1 and these immune therapeutics are gaining more interest. The Mayo group reported the first kind of experience with it and showing 44% response rate in the Richters with some CRs that were occurring. And then CAR T cells. The Fred Hutch group just recently published their experience in CLL using CAR T, and they had about 5 Richters that were enrolled, and also they did okay, a 60% response rate and about a 40% CR rate. Very short follow-up in that study. I think it was about 12 months, so we'll see if those are durable responses. So here's just a selected sampling. I tried to kind of look at clinicaltrials.gov. There's other trials that do enroll Richters, but not necessarily Richter specific, so I tried to keep it towards those that are enrolling Richter specific. There is a venetoclax R-EPOCH study being performed in Dana-Farber. I know Dr. Barrientos and Dr. Rai have a study at Northwell Health with ibrutinib, obinutuzumab, and CHOP. Dr. Kipps at San Diego has an obinutuzumab high-dose methylpred and lenalidomide. I think MD Anderson has recently opened a blinatumomab study. We have a study with selinexor plus rice, so adding it to a chemotherapy backbone, and with a recent addition of a Richter's cohort, so we have spots for 6 Richter's patients. We tried to enroll 1, but unfortunately he had progressed too quickly and never actually got the study drug and had to come off. Ublituximab, umbralisumab, and Pimbro. This is another IIT. Dr. Mado has started and is enrolling Richters and has a Richter's cohort. And then MD Anderson has a nivolumab ibrutinib study, which has shown some promising results. I throw the AZD molecule. This is an MCL1 inhibitor. I think it enrolls Richters, but I think we're all kind of waiting for this to salvage some of these venetoclax failures. As Dr. Coutre showed, they do poorly when they transform, and will this be a valuable molecule going forward? So what are our options in the era of novel agents? We can try to prevent it, identify these high-risk patients. Obviously needs to be done in a prospective, proper high-risk subgroup. Take what we know, target these pathways, not that easy to do. We don't have direct inhibitors of NIC or of MYC or NOTCH necessarily, rather indirect inhibitors with gamma secretase for NOTCH. And potentially even overcome all of these pathways and use immunotherapy. So I think there's some things out there. And then obviously I think what's important is to develop better preclinical models, and we'll show some data there. So we've been fortunate to develop 3 PDXs currently that we've sequenced and fully genomically characterized, and we'll be presenting that data at ASH, so definitely come by and see that data. But ultimately, very stable clonal architecture. It mimics what we see in the patient, and as in proof in principle, we've the group with Dr. Tiziana Viciti and Dr. Giaglio and our collaborators in Italy basically have shown this as a proof in principle using a preclinical drug, an FKB inhibitor, IT901, showing exquisite sensitivity to these Richter cells, and using it in an in vivo model. By giving it in vivo, you can see the spleens are smaller and basically does have activity in killing these cells. So potentially as a platform to use other agents, combinations, and novel drugs together. And so here's our experience. Unfortunately, I wish I could say we were doing something better than what we've seen, but unfortunately we are not. This is our past 16 patients we've treated in the past 2 years, and importantly, we also see about 40% of patients have transformed prior to observation. Very high-risk patients. 100% of patients had a TP53 disruption or notch. And ultimately, everybody who had transformed that was not treatment naive was on a novel agent. And so ultimately, you can see that these patients are still doing poorly. We have a lot of work to go, and hopefully we can get there with collaboration. And so these are the kind of the acknowledgments and the people we've been working with putting this all together. So thank you.